It is truly an honor to introduce our last speaker for this symposium. We have Dr. Pauline Maki joining us from Chicago, Illinois. She's a professor of psychiatry, psychology, and obstetrics and gynecology. She's also the director of the Women's Health Research Program and associate dean for faculty affairs at the University of Illinois at Chicago. For the past 25 years, she has led a program of research on women's health, particularly women's mental and cognitive health. She has over 200 scientific publications on this topic. Her research addresses important issues in women's health, such as how hormonal changes at menopause and menopausal symptoms affect women's cognition, brain function, and mood at midlife, and the effect of menopausal hormone therapy on cognition and mood. Dr. Maki is past president of the North American Menopause Society, treasurer of the International Menopause Society, and past chair of the Society for Women's Health Research Interdisciplinary Network on Alzheimer's Disease. She won the 2018 Women in Science Award from the American Medical Women's Association, the Thomas B. Clarkson Outstanding Clinical and Basic Science Research Award from the North American Menopause Society, and recently the 2023 Health Education Visionary Award from the Society for Women's Health Research. She has won several NIH awards for her research and service, serves as a research and career mentor to many students and junior faculty, serves on executive committees for several women's health advisory boards, and is a frequent international and national speaker. Her work is widely cited in the media, including in such outlets as the New York Times, Wall Street Journal, Washington Post, Fox News, National Public Radio, BBC, The Today Show, NBC News, ABC News, and The Guardian. Her work on mental health and pregnancy and the postpartum has received accolades from the Kennedy Forum, the news media, and the Office of the Vice President of the United States. So without further ado, as you know, just from that introduction, Dr. Pauline Maki is truly a trailblazer in the field of menopause and mental health. So I would like to introduce Dr. Pauline Maki.
Oh, thank you so much. Hello, everyone. It's such a pleasure to be here with you today. I'm excited to be presenting on a topic that's of great interest to me, and I hope to you as well. I have closed captioning turned on, so for those of you who have requested this, it's right here for you. All right, here are my disclosures. Okay, so today I'm going to be focusing on women's mental health across the lifespan. And I'd like to present this topic focusing on discrete points in a woman's lifespan. So we'll begin by talking about general differences. This is biological sex differences. So I will talk about sex differences, meaning the NIH definition of sex as a biological variable. So people born female, people born male. Then once we review the general overview of sex differences in mental health disorders, we will go into discrete stages of a woman's life. So we'll talk about childhood. We'll talk about what happens to the brain at puberty. What about mental health in college? A really important topic now, given changes in the epidemiology of psychiatric disorders in this population. We'll go into pregnancy. I'll share some of my own work there. And we'll talk about adulthood, menopause, and the later years. So a whole kind of overview of the entire woman's lifespan. So lifetime mental health disorder prevalence does differ depending on whether one's male or female. So if you look at the lifetime prevalence of any anxiety disorder, it's 36% in females compared to 25% in males. Any mood disorders, 25% in females compared to 17.5% in males. And then you can see that in contrast to those, what we call internalizing disorders, we have a sex difference where males show a higher prevalence of impulse control disorders in substance use disorders. And so there are select mental health disorders that are in fact more prominent in women compared to men. Now, you will notice the date on this slide is 2005, and you might say, well, why isn't she presenting more up-to-date information? The main reason that I use this 2005 study is because it surveyed a representative population of individuals in the United States. That's the most important. But secondly, they used the gold standard psychiatric diagnostic interview. So every one of those individuals had a face-to-face psychiatric diagnostic interview. Now, things have changed quite a bit in the United States in that past time. We're a much more diverse nation, and mental health disorders vary by race and ethnicity, as well as by biological sex. And so there's a pressing need for updated statistics on these disorders. And I think we wouldn't be surprised to hear that prevalence rates are generally high. But I use this to illustrate what the gold standard approach for psychiatric disorders is when it comes to sex differences. Understanding these internalizing disorders, depressive disorders, and anxiety disorders in women is very important because the World Health Organization reported that these disorders were among the top 10 leading causes of disability worldwide for females, but not for men. So a disproportionate burden of these, and one that ranks very high among all disorders for women. When we're looking for more up-to-date data, we can look at the National Health Interview Survey. So this is questionnaire data, but nonetheless, it gives us an updated perspective on rates of depressive and anxiety disorder symptoms. And you can see that these rates still remain disproportionately higher in females than in males, with 35% prevalence rates in females with more recent data. Let's consider the life course of when this sex difference in depression emerges. These, again, are data from Kessler, again, that gold standard study. You can see that the difference in the prevalence of depression emerges between the ages of 10 and 14. So this is when girls begin to show this higher prevalence, and this is maintained throughout the remaining lifespan. You see again a sharp divergence from the ages of 45 to 49, a time period that corresponds with what we call the perimenopause, a time before and after the menopause. And although these data are based on a very small sample size and are not reliable, we do have good data to suggest that that sex difference continues into later life. Let's consider now generalized anxiety disorder. So generalized anxiety disorder is this prevalent disorder that's characterized by worry about nothing specific, but worry generally. And you can see that when it comes to the lifetime prevalence, it's much higher again in females compared to males. And that's particularly true after midlife. When we look at the timing of the divergence of the prevalence rates in females and males, and we see that they're exacerbated at puberty and at the perimenopause, we begin to think of explanations that may have to do with hormonal transitions. So between the ages of 10 and 14, we consider the role of puberty during this time in adolescence. We know that there are women who are very sensitive across the menstrual cycle to hormonal fluctuations. Certainly not all women, but a subset of women are very sensitive to that. And then we think about pregnancy. Much of us are well aware of postpartum depression and its impact on women's lives. But we have data as well to suggest the onset of pregnancy itself is a period of vulnerability for depression for women. So we call that perinatal depression, the time around childbirth. And then when we look at the epidemiological data and we see that divergence in the mid-40s, we think about perimenopause. And perimenopause, when it comes to hormonal fluctuations, is not only characterized by an overall decline in estrogen levels as the ovaries shut down, but within that 4 to 8 year period of time when women are transitioning from being premenopausal to being postmenopausal, there are these spikes, these almost super physiological spikes in hormones that are a major determinant of anxiety and depressive symptoms at that time. And then, of course, we have the overall declining levels of hormones during aging. So we will talk about the role of hormones. But of course, women aren't prisoners to their hormones, and there are a lot of societal factors that contribute to some of the differences we see between men and women. So we talk about that as the gender effects in mental health disorders. Let's talk about post-traumatic stress disorder. So this is an anxiety disorder that emerges after trauma. Women are exposed to more high impact trauma compared to men, so including sexual trauma, and they're exposed to this at a younger age. And so you can see here that 10 to 12% of women will experience post-traumatic stress disorder at some point in their life, compared to about half of that, or even a third for men. What about substance use disorder? Again, generally, this is a behavioral health condition that affects more males than females, but you can see something that's emerging, and that's observed again in the most recent SAMHSA study, which is that among adolescents, and those of you who perhaps like me have children of this age, need to be aware of the fact that females at this age are actually more vulnerable to substance use disorders. And what we'll talk about is that one of the triggers for seeking substances is anxiety and depression in females. And so it's perhaps not surprising that that may be a catalyst for the abuse of those substances. Although the overall lifetime prevalence of substance use disorder is higher in males than females, there are important sex differences in these disorders. So a woman with a substance use disorder is more likely to have another disorder. So she's more likely to have depression, more likely to have anxiety. So she's 7.5 times more likely than a male to have a mood disorder, and 4.2 times more likely to have an anxiety disorder. Yet she's less likely to receive treatment. There are barriers to treatment, including pregnancy and trauma itself. So women don't want to often disclose the trauma that triggered some of these disorders, and so they don't seek treatment. They have greater cravings for substances, illicit substances, when they're stressed. And this has been shown experimentally in studies where you actually induce stress in the lab, and then you show or actually present in real time substances, and women will report higher craving. And the neurobiology of that is actually known. In women, one of the strongest determinants of substance use disorder is childhood trauma. And that association of childhood trauma with substance use disorder is stronger if you're female than if you're male. Women face a vicious cycle of substance use, trauma, and mental health disorders. And so oftentimes they'll experience a trauma. They will use, in part because of a lack of opportunity for mental health care in this country, they will self-medicate with alcohol, with cigarettes, with a variety of different substances. They become addicted to that substance. And addiction itself, especially in its most extreme stages, makes women more vulnerable to victimization, which again makes them more, exposes them to more trauma. So that trauma itself leads to vulnerabilities. So this is a vicious cycle that is the target for a lot of treatments for mental health disorders, especially comorbid substance use and other mental health disorders in women. We really need to understand the life course of this and the history of it. Let's talk about childhood. So women experience a greater number of ACEs, adverse childhood experiences. They experience more emotional abuse. They experience much more sexual abuse, but men witness more violence. And this experience, this exposure to more ACEs has lifetime consequences for women. It's not a determinant. It doesn't mean that somebody will develop a mental health disorder, but it is in fact a well-known risk factor. While the absolute number of ACEs is higher in women than in men, it's really at the severe ranges of ACEs that you see that women have more frequent exposure. So multiple trauma sources are more common in females than in males. And so it's a more severe childhood experience with trauma in females compared to males. Now, what does this mean? Well, if you have more than 4 adverse childhood events, you can see that that comprises a large proportion of individuals who are depressed. So the amount of depression attributable to ACEs is actually very large, particularly in women with multiple different adverse childhood events. But it's not just depression. That childhood trauma is associated with a higher risk of being a heavy drinker and of coronary heart disease. And there's a very strong link. I won't show it here today. We've published some data on trauma and cardiovascular disease in women, but let's just recognize that this is persistent throughout the life course. Child sexual abuse in the United States is a very significant problem. 14.3% of older girls and 6% of older boys experience sexual abuse during their childhood. And completed rape is not rare. It's 4.5% of girls. And sexual assault by a known adult, so somebody in the individual's circle, occurred in 4.3% of girls compared to 1.1% of boys. So again, another exposure that girls experience more often than boys. And when we talk about the link between childhood sexual abuse and mental health disorders, we can't underestimate its importance, especially in its most severe form of sexual abuse, where in its most severe form, the likelihood of drug dependence is a hazard ratio or an odds ratio that we don't see often in psychiatric literature. So a 5.6-fold increased risk of drug dependence, almost a 5-fold increased risk of alcohol dependence, bulimia, 2 to 3 times increased risk of major depression, anxiety, and panic disorder. So what experiences females have in childhood are a key determinant of their mental health for the rest of their lifespan. And so public health efforts to limit these exposures in women are critically important, and critically important in addressing the mental health prevalent diseases that women have. Let's talk now about puberty. So we showed at the beginning of this presentation that females have a higher risk of major depressive disorder beginning around the time of puberty. There are sex differences in the life course of depressive symptoms. So if you look here, you'll see that the age of peak velocity for depression, so the point at which you see more and more girls getting depressed, is much younger than that at boys. It begins at around age 13.5 compared to 16.5 years. And you can see that by the age of 20, that's when things have kind of leveled out within this age span. But a difference in the course of depression. The study I'm going to describe now is a neuroimaging study, but it's one of my most favorite studies of the past decade. So please bear with me when I share my interest in this study with you. So this study by Monique Ernst is asking a really important question about what happens to the brain at puberty. What happens in girls and boys at puberty to influence their depression and anxiety. So this is looking at areas of the brain that are involved in emotional regulation. And this is an area of the brain called the anterior cingulate cortex. Now, to regulate our emotions, and you might think about the last time you had to regulate your emotions. So maybe somebody said something snarky to you and you had to not respond. Or maybe your child was a little moody and said something and you had to put on your mom face or your dad face. and just be calm. That's your emotional regulatory system. And your anterior cingulate cortex plays an important role in kind of putting the brakes on your emotional center so that you don't react. Now, in order to do that, that area of the brain needs to be functionally connected. It has to be active at the same time that other areas of the brain are active. And the extent to which the brain areas that regulate emotions are nicely connected mirrors the extent to which we can regulate our emotions. We call that functional connectivity. So what happens at puberty is that girls begin to show less connectivity between these key emotion regulation areas of the brain and other areas of the brain involved in emotional regulation, whereas the boys show an increase in connectivity in those brain areas. So the onboarding of ovarian steroid hormones, estrogen and progesterone, are associated with these global changes in the emotional regulatory circuits in the brain. Now, how do we know that's important? Because this longitudinal study showed that lower connectivity in these brain areas at age 14 predicted more severe anxiety and depression when the girls were 16. And so the idea generated from this longitudinal study is that puberty, and particularly the hormonal changes at puberty, appear to amplify the risk for internalizing symptoms in girls by reorganizing emotional circuitry in girls. So if we look at the COVID pandemic, we also see an increase in symptoms, particularly anxiety and depressive symptoms. And so this is the best data that I had been able to find looking at depression and anxiety symptoms pre and post-COVID. And for those of us who had children who lived through this, this might sound familiar. So you see here higher levels pre versus post-COVID. You see post-COVID levels of depression markedly increased, right? Markedly higher anxiety, generalized anxiety, this general worry, and also social anxiety, in part because of the social isolation. Whereas in boys, you see this increased anxiety as well, but not to the level that one saw within the females. So the COVID pandemic had a main effect on mental health in adolescent females. Now, what about college? So if we look at trends in mental health, we see that over the last decade, the prevalence of anxiety and depression has increased dramatically, and it continues to increase in individuals in college. And the 12-month prevalence of these disorders is remarkably high. This is being diagnosed or treated for mental health disorders. So this isn't just a worsening of depressive or anxiety symptoms on a survey. These are people whose symptoms were severe enough that they were diagnosed. We have higher rates of anxiety, higher rates of depression, and higher rates of panic attacks in females. But look at the absolute level of this. The 12-month prevalence in college-aged females for anxiety was 28%. So very high rates of anxiety disorders. Anyone else hearing that kind of static? No. I'm going to just mute this. I hope it's okay. Okay. Feel free to put in the chat if there's any issues with my audio. Okay. So let's look at COVID mental health and substance use in college students. So what effect did the COVID pandemic have on that? So in this, to the left, this greenish blue bar, seafoam green, is pre-COVID, and the blue is during COVID. And you can see, again, higher rates of depression, and lower rates of illicit substances and lower rates of binge drinking. So not everything during the COVID pandemic worsened in adolescents. They had less access to illicit substances, less access to binge drinking. And so rates of those behavioral disorders went down during the pandemic. However, mental health had a significantly greater functional impact, so that mental health impaired academics in 30.5% of students in this Healthy Minds studies. Okay, let's talk now about the prevalence of sexual assault, which is all too high in recent data. So any experience of sexual assault is surprisingly high. So females have at least 14% of college-age students report non-consensual sexual touching, 5.3% report a penetration attempt, and 3.4% report rape. So these rates are, any number here is too high, and these rates are much too high. So it's not exclusively among females. These exposures are also experienced by males, also an important exposure. It's just that females have higher rates of these. Mental health in college-aged heterosexual, bisexual, and lesbian women is a particular concern. The mental health of bisexual women is among the worst. Compared to heterosexual women, bisexual women and lesbians had a greater likelihood of having any mental health issues at college, and a 4 to 5-fold, imagine the magnitude of that, increase in self-harm, suicidal thoughts, suicidal attempts. So the most severe consequences of mental health are experienced all too commonly by sexual minorities, and they utilize significantly more mental health services. So policies that support mental health services for sexual minorities can go a long way in addressing this issue. Let's move now to pregnancy. We, in our research studies, look at the perinatal perinatal period as a window of opportunity to assess mental health in women generally. So we often, by default, when we think about pregnancy and depression, think, oh, okay, so a woman has this increased risk of having postpartum depression. I think we can reconceptualize pregnancy as a time in a woman's life where she actually gets screened for mental health disorders, minimally depression, sometimes anxiety. And this, for a large segment of our population, is the first time she's going to have that opportunity. And because it's done as a standard of care, we can be able and be screening women who have had a history of these but have never been screened before. And so it's a very powerful window of opportunity, even if mental health disorders are existing. The rate of pregnant women with a depression diagnosis at delivery increased 7-fold. Think about this, a 7-fold increase from the year 2000 to 2015. So this problem is only getting worse. And if you look at COVID in women's mental health, women who are pregnant, postpartum, miscarrying, or experiencing intimate partner violence were at especially high risk for developing mental health problems during the pandemic. And so that was a really important target for us during the pandemic. Now, if we look at trends in chronic conditions among women of reproductive age, we can look at depression, we can look at asthma, and we can look at chronic hypertension and diabetes. And we hear about, efforts to stem these, if you will, physical illnesses in women, but look at where depression ranks in relation to those. It's just much more prevalent. And so among mental health conditions in women in reproductive age, we can't underscore enough the importance of mental health. In our work, we focus on low-income women of color, mostly Black women and Latinas living in the South Side of Chicago. That's because this is a greatly underserved population of women, and compared to white women, the odds of a major depressive disorder before childbirth were 5-fold higher in Black women, 2-fold higher in Latinas, and this discrepancy persists into the postpartum period. Very few women get treatment for postpartum depression, regardless of their race, ethnicity, and sometimes even financial status. Imagine only 4% of Black women and 5% of Hispanic women receive postpartum mental health care. So way too few, but only 9% of white women did as well. So this is a problem that all women face, though underrepresented women experience it more commonly. The follow-up care of women, particularly Black and brown women during this time, is a really important consideration. Women change, right, from being seen by an OBGYN, and then they don't get seen anymore, and they're transferred, the child's care is transferred to a pediatrician. So who follows a woman during that period? Who maintains continuity of care for women? It's a real challenge within our healthcare system. A lot of federally qualified health centers are doing a good job following women. One shameful fact of our country is that maternal mortality is increasing while it's decreasing in other high-income countries. So we fail in making appropriate strides in maternal mortality. What are the benefits of depression screening? Well, the screening process itself, just asking the question, via a survey, if you send those test results to the clinician, the very act of screening leads to a 2 to 9% absolute reduction in depression prevalence and a 10 to 34% absolute increase in the likelihood of remission. So just that screening act as a public health intervention is helpful. We take a kind of state-of-the-art comprehensive approach to screening for mental health disorders and behavioral health disorders. So behavioral health, I mean substance use disorder, by using something called computerized adaptive technologies. So Pauline, what is that? So if you've ever taken a screening test, you will get a piece of paper and it'll have some questions, and you might respond to those questions on a scale from 1 to 5, where you say not much, somewhat, moderately so, etc. I get the same questions that you get. Well, Robert Gibbons, who's a phenomenal scientist and a phenomenal human being, developed this process. He's a mathematician. He applies his work to psychiatry. And his idea was, can't we screen better? And the idea is that he creates these banks of items that correspond to the kinds of symptoms that people have with various mental health disorders. And he asks, through this real-time web-based platform, a question. And then depending on the respondent's response to that question, the database will pull in the question that at a population-based level was the most likely to be sensitive to the diagnosis. So in other words, has the highest likelihood of predicting depression. And then depending on the answer to that question, they get asked another question. And so this questionnaire is tailored in real time to the person's symptoms. And there are modules for major depression, anxiety disorder, meaning generalized anxiety disorder, mania, substance use disorder, post-traumatic stress disorder, and even suicide. And so this is what we use in our perinatal studies. We have found that screening for depression this way is more sensitive to depression than standard questionnaires like the Patient Health Questionnaire 9. In fact, in absolute terms, we've published findings that this approach picks up on 5% more cases of depression among a population. In other words, 5% of women would not have been detected. We validated that as true positives. So medical records showed that those cases, in fact, were true cases of depression. So there's a whole revolution in the way that we're screening. We and others now are screening for mental health disorders in women. When we do this, we see incredibly high rates of depression and anxiety in underrepresented women. So at 4 points during pregnancy, the risk of depression in Black women was 22.5%. This is a diagnosis, not elevated symptoms, a diagnosis, and 25% in Latinas, and perinatal anxiety was also high at 17% and 14%. We found when we studied women, a large population of women across the entire first trimester, second, third, and the postpartum, that depression screens were highest in the first trimester and then declined thereafter. So if we only screen in the postpartum, we're really missing this high rate early in pregnancy. And positive anxiety screenings were highest in early pregnancy in Hispanic women, but late in pregnancy in Black women. So this idea that you put Black women and Latinas in the same analysis because they all fit under this underrepresented category is misinformed. We need to look at the life course, or the natural history of mental health disorders in each racial and ethnic group individually. The nation is making some strides in screening for perinatal depression, but what I'm going to show you now is that our data suggests that that's not nearly enough. In other words, when you screen for all of those mental health disorders that I showed that the CAT-MH can screen for, you see that comorbidity is very common. So that if you take a population of women, all of whom had a diagnosis of depression during pregnancy or the postpartum, 48% of those women have something else. 26% had one comorbidity, 10% had two comorbidities, and 12% actually had three. That's a typo. What I want to show you here is this population. So in our low-income women of color population, 9% of the women who screen positive for depression also screen positive for generalized anxiety disorder, substance use disorder, and post-traumatic stress disorder. So they had three comorbidities, and it was 9% of that population. So screening for depression is great, but it's just the tip of the iceberg. Getting care to women during pregnancy is challenging. It's challenging no matter who you are. We know that there's a national shortage of providers. We've addressed this issue by trying to make evidence-based treatments available free of charge through women's phones. So you just pick up your iPhone and you can do your evidence-based psychotherapy, which is cognitive behavioral therapy. This is through an app called Sunnyside, which was developed by my good colleague, Jenna Duffy, who's a clinical psychologist and who has done many, many clinical trials of digital interventions for mental health. And so this is what we offer women. And for women, it's minimally a bridge to care, but many women do this in the privacy of their home. Once a week, they'll get a module that they can complete. It trains them in the two major components of cognitive behavioral therapy, so cognitive reappraisal and behavioral activation. So we have tailored the content based on intense focus groups with patient populations so that the videos and scenarios that we show are relevant to the lives of women with these disorders. Online tools are effective. Effect sizes range from 0.36 to 0.78, and they're on par with face-to-face treatment. So they offer a really nice alternative for those people who are comfortable getting their treatment this way. One of the major breakthroughs in the field of psychiatry has been a new treatment for postpartum depression. After pregnancy, levels of progesterone, that progestation hormone, that's why it's called progesterone, plummet. Progesterone has a breakdown product, a metabolite called allopregnanolone that also plummets at that time. And that allopregnanolone plays a really important role in our ability to maintain an optimal mood. And that decrease in allopregnanolone, if reversed, can have some pretty profound effects on postpartum depression. So if you add back allopregnanolone, you see a pretty impressive rebound in mood. So women can have a pretty impressive effect. Currently, the FDA has approved only an intravenous form of this treatment. Works pretty rapidly, but there's a barrier to getting it out to women. But the FDA is currently reviewing the pill form of this intervention too. So they should know, I think, in August whether or not the new pill-based form of this will get approved. Treating women's mental health during pregnancy is really important for the woman's own well-being. It also turns out that it seems to be really important for the infant. We can now do, I don't do it, others do, neuroimaging studies in infants as young as 6 months. Okay, 6 months old, you can put these infants in brain scanners. And there are studies that show that if you do that, and if you compare the extent to which those emotional brain networks, remember the ones that we reviewed at puberty? We talked about the anterior cingulate as an emotional regulation network. If you look at that network in the offspring of women who are depressed, you see alterations so that the brains of those children are not as functionally connected in the same way as in the brains of children who were born to moms who didn't have depression. And the fact that you can pick up at this at 6 months is really fascinating. It may be a genetic predisposition. It may reflect parenting styles. It may be an interaction between the two. It could be something like the gut microbiome effects. There are multiple explanations for this, but the point is that prenatal depression itself appears to be associated with altered brain function in infants as young as 6 months. Let's move to adulthood. Harassment and discrimination in the workplace are key determinants of women's mental health during adulthood. Women report experiencing many types of these exposures. This is work by Dr. Respenda here at UIC. Sexual harassment was more prevalent among women than in men, and among Black women in particular. Mixed race individuals, who we don't study as often as we need to, experience the highest rates. And those experiences were associated with problematic drinking in women. So policies that are put in place to limit these exposures to women are also important. Here's work by my good colleague, Rebecca Thurston, showing that sexual harassment is not only associated with depression, but with hypertension. So that these exposures, although we commonly think about their effects on women's well-being mentally, have profound effects on women's physical health as well. Here's our study on carotid intimamedial thickness. You can see that women who have no sexual assault, this is a longitudinal study, have less plaque in their carotid artery compared to women who have that exposure. And this is controlling for everything under the sun. And you see this reliably as well in the follow-up. And you can see an exacerbation, an accumulation of plaque in those women as well. And you can see that the change in the plaque index is markedly higher in women who report a history of sexual assault. Okay, we have at UIC a Building Interdisciplinary Research Careers in Women's Health grant from the NIH. And during the COVID pandemic, our mentees got together to study work-life stressors. They said, this is a problem for me, is it a problem for others? And what they found is that the COVID pandemic had a much more profound effect on work-life balance and productivity among women compared to men. Women experience more stress caring for someone ill or disabled. They experience more stress with childhood responsibilities, with their own personal health, and just about many, many aspects of their scholarly productivity, their ability to carry out their teaching and advising and committee responsibilities, and their clinical responsibilities. So for those of us in academic medicine, the lived experience of women during that time period and its effects on their academic productivity were profound. We at UIC had bridge funding that was given out to faculty who experienced these stressors during the COVID pandemic, and the female faculty said it went a long way in addressing some of their concerns, but of course couldn't reverse everything. We'll go on to menopause next, and then the later years, and then I'll finish up. So the perimenopause, the time before the final menstrual period and after the final menstrual period, is a vulnerability period for experiencing just worse mood overall, even if it doesn't reach the threshold of major depressive disorder, but also for major depressive episodes. So the more clinically significant form of depression. If you look at a snapshot of major depression in a group of women, say 100 of them, 5 would have depression if they were premenopausal, 9.1 if they were peri, and 9.8 if they were post. And this risk increases with advancing menopause stage when you account for the fact that women are aging. And this is higher than what you see for men. So what about major depression in the perimenopause? It turns out that increase, remember from that epidemiological slide, that increase in perimenopausal depression is largely driven by women who have a history of depression. And that's not a small segment of the population, as we saw, because the lifetime prevalence of depression is high in women. So the likelihood that they'll experience a recurrence of depression in the perimenopause is high. First time new onset of depression during this time in life is rare, but it does occur, particularly to women who we know are estrogen sensitive. So there's a subgroup of women for whom the withdrawal or the onboarding of hormones triggers mood disorders. Perimenopause is also associated with another bump in psychotic disorders. So if you look at schizophrenia, you see another increase in the prevalence of schizophrenia at midlife. So it's not the hormone levels. So it's not whether you're high or low per se that trigger mood problems. And parenthetically, if anyone measures your hormones during the perimenopause, they're not doing you a service because those levels are very variable, and it's hard to make any conclusions from those kinds of approaches. It's the individual differences in the sensitivity to hormone changes. So let's take the example of postpartum depression. And I would imagine that most of us agree that postpartum depression is a mood disorder that's triggered by hormones, right? But the majority of women don't experience that. That kind of idea that there's a subset of women who are sensitive to that acute hormonal withdrawal pertains as well to the perimenopause. So it's not the levels, it's my own sensitivity to hormonal withdrawals that matter. And it's not just some biological phenomenon. The extent to which your body can handle those hormonal withdrawals depends on how much stress you have in your life. It depends on your genetics. It depends on your personality, how much social support you have, the extent to which you engage in healthy behaviors. So it's a multifactorial effect. And then finally, let's talk about later adulthood. Women, so this is a gender difference. It's not a biological sex difference. What we're talking about now has to do with the role that women play as caregivers. So 2/3 of caregivers to older adults are women, and 1/3 of dementia caregivers are daughters. So it's more common for wives to provide informal care than for husbands to do that. And females, when they are caregivers, they have a more intense caregiving experience. They spend more hours doing that. So that 70% of full-time dementia caregivers were women. Women who are in this capacity, and many of you may be in this capacity. I have a lot of friends who are struggling with this kind of sandwich generation. They are asking for mental health services. So most of these women desire either individual counseling, they desire respite care, and they desire support groups. And although this is not uncommon among men, again, more women report that desire than men do. What does this stress of caregiving portend for a woman's cognitive health? Well, depression was associated with a 36% increased risk of subsequent decline in cognition in older adults. so that these affective problems are a risk factor for cognitive decline later in life. And we know that caregiving is one of the factors that can contribute to affective problems later in life. And so I've taken you on a bit of a journey here today. I've talked about the general differences that we see between males and females and the prevalence of mental health disorders, and gone a bit over the life course. We've talked about childhood, and in particular, childhood trauma and sexual trauma. We talked about puberty and how the onboarding of estrogen and progesterone changes the way that the brain is wired in a way that predisposes girls to mental health disorders later in life, and how at the same time they're experiencing a lot of trauma, a lot of exposures within the context of the college environment. We talked about pregnancy as a window of opportunity to screen for mental health disorders in women generally. We kind of celebrate new approaches to screening for mental health disorders, which are good in detecting more cases of mental health disorders, but unfortunately also reveal a need to treat comorbid disorders, though there is help on the horizon in terms of new treatments that target the very specific neurobiology of mental health disorders at that time. We talked about adulthood and the workplace in particular, and how policies need to be put in place to limit that exposure if we want women to maintain good mental health at that point. We talked about the menopause as a window of vulnerability for depression, also for schizophrenia and others. Although that happens to a minority of women, it's common among women with a history of major depression. And then we talked about the later years and women's role as caregivers and how that predisposes them to mental health concerns, how they're expressing a need for those disorders, for help with those disorders, and how the irony is that they are, if you will, punished for being in that role, because the more stress that women have, the higher their own likelihood of developing dementia is. And I wouldn't be able to do this work without all of my dear colleagues. Robert Gibbons here is the one who developed the CAT-MH. Here are the 20 plus women who worked in my lab. These individuals came together in some of the focus groups. And then Jenna Duffasey, of course, is my partner in everything I do with Sunnyside, that online app. So with that, I will thank you for your time and for this opportunity. And if there's time, I'm happy to take questions.
Thank you, Dr. Maki, for that very comprehensive presentation of mental health across the lifespan. We're going to take questions from the room, but also going to monitor the chat and the Q&A. So for those of you who have questions, I'm going to walk around the room with a microphone.
Hi, Dr. Maki. That was great. Thank you so much for such a comprehensive overview. I actually sent your slide with hormonal to my friend who's very interested in hormonal changes across the life course. One of the questions I had is regarding, you put college as a sensitive window across the life course, which made me consider, I've always thought of it as considering like biological time points, but you put college because of the dynamic changes that I imagine that are going on. Why not thinking about retirement? I feel like it's a time period of great transition, and it's not quite later years, and it's not quite menopause. And so what are your thoughts about considering the differences in mental health by sex for the retirement ages?
Thank you so much for that really insightful question. I appreciate the suggestion. It's not a topic that I've researched extensively, but we do know that from other work that mortality rates actually are higher in men post-retirement than they are in women. And you get this kind of peak in sudden death in men following retirement, which has led to a lot of the Fortune 500 companies actually enacting these programs to help individuals plan for their retirement. So it's interesting that perhaps some of the, and oftentimes it's cardiovascular risk factors, some of those may be more prevalent in men. I don't know about the depression rates between the two. it's a fascinating question. And I'm going to follow your suggestion for what I'm asked to do this again. So thank you so much. And it's actually, now that I think of it, it's actually a question that I haven't thought about examining in my longitudinal studies of women, but I most certainly could, because we have their annual rates of employment. So we can know if it gets better, it gets worse. I suppose it depends on how much you like your job.
Thank you, Dr. Maki. Anyone else in the room or on the Zoom crowd? Okay, well, thank you so much, Dr. Maki, for your time this afternoon, and again for a great comprehensive presentation. We'll see you at NAMS this year.
Yeah, looking forward to it. Thanks for the opportunity. Have a good night.